Friends, good evening to all.
Bring your labor in here with this lesson.
I am happy to get you all together for this another meeting of Inform. And we have been going steady all these years since the pandemic, every month, the last Saturday. And today we have the pleasure and the honor of having the President Asdin, Dr. Bharat Sachdeva, with us. And it's a great honor that many of our colleagues or friends are doing so well in US and especially as office bearers in Asdin. And we have had most of them coming joining this meeting. Not only that, they've been sort of so interested in interventional nephrology growing in our country. They didn't stop with their activity there, but from the beginning of Avatar, I remember it was always Asdin members of Indian origin who used to come and push us, motivate us. They've been our sort of uh, people who made us think about interventional nephrology, and they are continuing to help us. So welcome, Dr. Bharat, and Dr. Lal is not new to us. He is great teacher, and he has been visiting India. And I met him first when he came to Ramachandra, and when Girish was a young second year PG or so. So that was a meeting on intervention nephrology conducted at Ramachandra. He was the, as ISN teacher, he came. And he has been with us for many meetings. And welcome, Dr. Lal. And I think to introduce him by his biodata because he's so familiar to us. And Dr. Bharat also said, yeah. So he started from Glancy Medical College, India. So sometimes it is nice to know the roots, all these people who are doing so well in US. And coming to the faculty from our place, we have Dr. Lobo, a senior man, who has always good comments to make in whenever people come with issues. And he was one of the early presenters of interventions, central vein and others in our Indian meetings. And we have Hardik, Hardik as part of India team, and he's so reachable now. Dr. Rajpurkar, he been a mentor and a hero because I was renal artery and he was the only one doing renal arteries in the country. So I used to have him as my, if not directly being a student, I used to envy him so much. From there, I have the legacy of that institution in Dr. Hardik. And Girish, of course, is the cornerstone or pillar of evolving, emerging interventional nephrology in our country. So he's with us, and I have chosen all this especially because they are all very much into uh, cath lab interventions, and nephrologists doing cath lab interventions are not it's quite new here, and many people are very eager to join. So I thought instead of having didactic lectures, let us have cases, just cases which they did a few months ago, and try to get some cues out of it, points out of it, and get more points from the teachers who are sitting. So in that manner, we'll start with Dr. Anish, who is here with me as interventional fellow trainee here. And Anish, can you share your slide?
Yes, sir.
So he'll be presenting two cases which were done, during his stay here in my center, which will be followed by Dr. Karthik has a case to show, and I'll be also sharing one case, and Akash the last case. But we'll see that we are very short with the presentation. We'll go straight to discussions and the things to be learned from these cases. Uh, yes, Anish.
Shall I start, sir?
Yes.
Good evening, everyone. My name is Dr. Anis. I'm an interventional nephrology fellow at Kidney Care Center, Tirunelveli. I'll be presenting two cases today that we did in the last month or so. The first one is titled Complete Cutoff. Is it a complete loss of hope? So the index case is a 37-year-old male who is a known case of CKD on maintenance hemodialysis since last 3 months, and the access is a right IJB tunnel catheter. So 3 weeks back, we did a left RC fistula for the patient. And while we make RC fistulas or BC fistulas, we have a habit of passing a feeding tube into the vein to check for the outflow. So when we were doing the same for this patient, there was some resistance around the elbow, and the patient also complained of some degree of pain. But we were able to maneuver the feeding tube into the vein, and we created the left RC fistula. And also there was good still post procedure. So around 3 weeks after this, the patient came to us that he is not experiencing any thrill in the AV fistula since the last 2 days. So we took him for a Doppler, and the juxtaanastomotic segment showed some stenosis with a thrombus, and we shifted the patient to cath lab. So in the cath lab, we placed this 6 French radial artery sheath, and we took an angiogram. And as we can see, the yellow arrow, it is marking the site of the anastomosis, and there is complete cutoff of the radiocephalic fistula. There is no contrast that is going into the fistula. So what we did after that was that we took a 035 Terumo guide wire along with a 3.56 French GR diagnostic catheter, and we somehow tried to manipulate the guide wire to enter into the anastomosis. But after trying for long, we were not successful. The 035 guide wire was not going into the, not crossing the anastomosis and going into the RC fistula. So then we took a 6 French guiding catheter, and we took one run through Terumo 014 PTCA wire, and we somehow manipulated it. And after long efforts, we were able to cross the anastomosis. So this first image is showing the PTCA wire that has just crossed the anastomosis to enter into the RC fistula. And we advanced the guide wire further, and here we can see the position of the radial artery and the PTCA wire that has traveled into the RC fistula.
Anish,
Yes, sir.
did we use a NC balloon to, maneuver?
Yes, sir.
Yeah.
Yes, sir. Like just after passing the guide wire, we took support. Sorry, sir.
Yeah, carry on.
Just after advancing the PTCA guide wire, we advanced a 2 into 20 PTCA balloon to give support to the guide wire. And the balloon and the guide wire was forwarded into the RC fistula. With the yellow arrow, we have marked the PTCA balloon. So after this, the PTCA balloon was inflated to 6 atmosphere for 30 seconds. And this dilation was carried out to the entire left anastomotic area, as shown in the pictures. So, this is the angiogram that was taken after the initial dilation. As you can see that some amount of contrast is now going into the RC fistula, but the flow of the contrast is in a very thin stream. Then we removed the 2 by 20 balloon, and we put a 3 by 20 PTCA balloon, and we did the same thing again. We dilated it in the anastomotic, juxtaanastomotic area, and throughout the juxtaanastomotic area, as we are shown in these pictures. And after that, we removed the NC balloon, and we placed the 035 guide wire through the guiding catheter, and we inserted the 035 guide wire. So in this image, you can see that the PTCA wire is lying in the cephalic vein, and the 035 guide wire is going into the basilic system. After that, we removed the PTCA wire, and we put a 4 by 40 Boston Scientific Mustang balloon, and we inflated it to 6 atmosphere. And this was done through the entire juxtaanastomotic area. And after that, we took one more angiogram. This is the angiogram after the dilation with 4 by 40 balloon. And in the lower forearm, now we can see that the contrast is easily going into the RC fistula. This is around the lower forearm. And this is the angiogram taken around the elbow. So here we could appreciate that there was some amount of narrowing in the elbow region. And this was coinciding with the place where the patient was experiencing some form of pain when we were trying to put the feeding tube during the surgery. So we thought that this might also be a stenosis. This is the angiogram around the upper arm, showing again good flow, and angiogram around the shoulder. This is also showing good flow. So then we took the 4x40 Mustang balloon and placed it around the anastomosis and inflated at 4 atmospheres. And this was the final angiogram. We can see that now the contrast is very easily flowing into the radiocephalic fistula. So the patient was given tablet clopidogrel 75 milligram post procedure, and we also gave unfractionated heparin infusion for 1000 units per hour for 5 hours, and the patient was discharged. So some of the points that we wanted to discuss regarding this case was whenever we create a fistula and there is resistance in the passage of a feeding tube, so should we go for an intraoperative venogram and venoplasty in the same sitting? Then the second question is, how long after AVF creation is it safe to do interventions? For this case, we did it at 3 weeks. And what is the methods that are used to tackle complete cutoffs? And what is the post-operative management for such patients? Should we routinely put the patients on anticoagulants or only antiplatelets should be sufficient? Thank you.
I think we can take a discussion after each case because at the end we may be concentrating only on the last case. So the panelists, you can come out with your comments on this case and any other suggestions you would give or any teaching points.
What was the pre-procedural flow and what was the post-procedural flow? Of course, pre-procedural, the flow is 0 because it was a thrombosed access. But what was the flow in the radial artery? By any chance, did we measure any flow?
No, sir, we did not measure the flow at that time.
Okay, okay. Then looking at that angiogram, there is one flow going into the collateral. Like, there is a collateral arising just at the junction of the juxtaanastomotic, stenotic, juxtaanastomosis and the body of the AVF. And in fact, after the fistula had opened up, the flow was predominantly going into that collateral channel. So did you contemplate doing anything for that?
Anish, you can go back to that to see for the collateral.
Yeah, if you can run
Collateral
the
was there in the first
angio after the flow came. Yeah, yeah. Yeah. So you see, there is a collateral channel coming up. So yeah, yeah, yeah. If you can just yes. So yeah. So you did anything for that, or you just want to observe?
Anish,
Sir,
did
sir.
this persist even at the final outcome angio?
Yes, sir.
Yes, sir, it was still there. But
Yeah, last angio you can show, Anish, after the procedure also.
yes, sir.
Final run. Just yeah. Yeah, you see there?
Yeah, it is there. So, but that is actually equally good size vein, right?
Yes, sir.
So we should look at the patient again.
Yeah. So
good.
yeah. So Anish, did you look at the flows after the procedure was done? Doppler flow measurement, anything of that sort?
This happened,
Yes.
just a week ago or something. I think we should keep this point in mind and look for this collateral and to keep this working, we should tackle this.
Yes, sir. Yes.
Keep that in mind.
Yes, sir.
Yes,
Yes.
sir.
Okay, Anish. Yeah. Thank you. It was a nice case. So I think the learning point for me is when the wire is not engaging the stenotic segment, you use the balloon to manipulate and move out. So I request my seniors to add their points.
Anish, a quick question.
May I, sir?
So you mentioned that at the time of the creation of the fistula, we try and insert the feeding tube. The intent, I guess, is to make sure that there is no stenosis in the outflow veins.
Yes, sir. Yes, sir.
Do we routinely do venous mapping with ultrasound before we create a fistula?
Yes, sir. We do it for every patient, but in the mapping, I could not find any specific segment. But when we did the fistula, then this problem arises.
Okay. So on mapping, there was no obvious
Yeah,
stenosis
we
in the
couldn't.
No
cephalic
obvious
vein.
stenosis was there. Yes.
Okay. So yeah, so sometimes your feeding tube may get caught up in a side vessel because you're
Yes.
not doing it under fluoro, right? It's under
I see.
you're doing it blind, so it may be in a collateral channel or a small channel or maybe against a valve. So that could also
Yes.
cause resistance.
Yeah,
So that may not mean that it's a thing. My other point would be, I think, why did we have to, or why did after the two balloon went through, um, the next balloon I would have used would have been maybe a five balloon, because the vein should have been at least 3 millimeters, 2.5, 3 millimeters to begin with when you created the fistula. Any reason that we
it
went
was.
in on the 3 or 4 balloon?
How long was it? Anish?
It
It
was
was
only 3 weeks
after.
after the creation, so we were a bit cautious so that we do not over distend the vein. That's why
Okay.
we used 4 balloon on this side.
It was 1 week after creation of the fistula.
Three
So
weeks, sir.
3 weeks, right? 3 weeks.
No,
Yes, sir.
it was 3 weeks, Anish.
Yes, sir. 3 weeks after creation.
No,
Yeah, so because if the fistula was running for 2, 3 weeks, it should have had some dilation. And again, the ultrasound pre-procedure should have maybe helped you in looking for what was the vein diameter in the segment of the fistula that can then guide you in terms of the using the right balloon. Because if you don't have any flow, then it becomes really difficult to know what the venous diameters are.
Anish,
Lal,
Yes,
any
sir.
comment?
Yeah.
can I ask? So, venous mapping by ultrasound, how do
Yes,
you
sir.
do it? Do you tie a tourniquet, measure the distance from the skin to the vein, and then vein diameter?
Sir, first
How do
we
you do
do
it?
it without a tourniquet, and after
Ah,
that we do it with a tourniquet to see if the vein is distending or not.
yeah, because venous mapping is very important, and all it depends who's doing it. That gives you the real roadmap of what are the tributaries and where exactly the anastomosis should be, how deep
Yes, sir.
it is to access. So just I think there's a standard of practice from the colleges, I think. So
Yes, sir.
So Anish, really nice job. The immature fistulas and early thrombosis of a fistula is not easy to handle, and I don't think there is one way which is the best way to do that. Couple of comments that I have is I agree with Bharat that maybe I would have gone to a 5 minimum to dilate it. Because you when you did the ultrasound and you noticed that the juxtaanastomotic was a little bit narrowed and with the clot, you would have seen the outflow vein also, which was not clotted. Considering that there was a collateral, that means from that point onwards, the vein would not have thrombosed. So you would get your minimum vein diameter, undistended vein diameter. And so when you distend it, it should be able to handle a little bit more. But having said that, immature fistulas, you're absolutely right. You have to be cautious because it can rupture, especially if you're using small balloons. Because when you use a small, short length balloon, the ends of the balloon will stretch more. And if the vein beyond that is going to go into a spasm, or sometimes it is associated with some collateral, there is a tendency for them to rupture. So in fistula maturation, especially the balloon maturation, sometimes I go with a little bit longer length balloons. So if you're doing it, then do it in one go, multiple one, let the vein spasm around it, just leave it inflated for a few minutes so that it relaxes before you take it out. Couple of things for your very first question that you had, which is should we consider an intraoperative venogram? So for all the benefits of doing an ultrasound, ultrasound will not tell you when you connect an artery in the vein, what path the blood is going to take. Okay. unless you do a contrast enhanced ultrasound, which none of us do it. So all that ultrasound is telling you is, yes, there is a patent vein, but when you connect the artery to the vein, how that blood is going to flow or which path it's going to take is not shown, right? So if you're already there, instead of putting the feeding tube, I would rather put a small a vascular whatever dilator and just inject 2 to 3 or 5 ml of contrast and do a regular standard fluoroscopy, and you'll see which path that the blood is taking, or once you connect it, which path that the blood is going to go into, and then you can see if there is any associated narrowing. I don't have an opinion about whether you want to angioplasty at the same time or like what you just did, connect it and then bring back in 2 weeks when the blood is still flowing and figure out and do more. The one final comment that I want to make is the approach that you have taken with the distal radial artery. And you beautifully dilated the arterial anastomosis, but you connected the fistula to the distal radial artery. If you go back to your final image, you notice that there is the proximal radial artery, which feeds into the anastomosis, is now narrowed down. I don't know whether it is a spasm or is it a post-surgical change which has already occurred. That means your fistula is now dependent upon the flow from the ulnar artery through the palmar arch into distal radial and then come into the fistula, right? So most of the time, if fistula is at least 3 to 4 millimeters, I would just approach through the fistula, get into the proximal radial artery, and when you put the balloon, make a U-turn and balloon the anastomosis so that the flow is coming from the proximal radial rather than the distal radial. I mean, both are okay. As I said, no technique is perfect, but just a food for thought. And I'll stop it here.
Thank you. Yeah, and I was going to ask Lal, because from their place, people don't like radial approach. So I was going to get his comments on this. So even in this case, venous approach would have been better, I think, right? But somehow here I find more and more people are, quickly going on to radial. I don't know whether it is right, but that's what is happening here.
I mean, for me, it's a convenience and it decreases the post-procedure observation period, because if I entered the fistula or the vein, all that I have to do is put one suture and the patient is out of the center in 20 minutes, right? I don't keep them for too long. But when you go through the artery, then you have to worry about it. So
but also the risk of radial artery occlusion after radial access, looking from the cardiology literature, is a significant fraction. And like you said, in a radiocephalic fistula, at least 30-50% of the flow sometimes comes from the distal radial artery. So you get flow both from your proximal and distal radial artery. So if you do compromise that, and I think in this patient, even on the first angiogram, there was some pathology in the inflow radial artery as well, which is also going to be a challenge in trying to mature that access.
Right. Before we move on to the next case, a quick question to Hardik and Girish. What is your practice now? You're persisting with radial approach, or have changed to?
No, sir. What we do is we do the ultrasound of the radial artery, distal radial artery, and see what is the diameter of the radial artery, proximal and distal. Then, based upon the diameter of the radial artery, then we decide whether we are going with the radial artery or not. Second thing is sometimes, like in this case, the vessel, the proximal feeding vessel is also stenosed. So we don't hesitate to take the brachial artery approach, sir. Sometimes, we take the brachial artery approach, do plasty of the entire feeding artery, like, the proximal segment to the anastomosis, then we plasty the anastomosis and the distal radial artery. Once we have done that, then we take the approach of either distal radial artery or the fistula, because now we are very much sure that the diameters have increased, and we do that. But yeah, we are very much inclined towards the radial artery approach.
Hardik?
Hello. I agree partly with Girish, but generally we also look at the pre-procedure ultrasound, because pre-procedure ultrasound radial artery diameter and the flow. These are the two key things which I always look before puncturing radial artery. Because many times when once you puncture that whatever stenosis or whatever angiogram we see, it may be a spasm, or we don't know whether it's true stenosis or it's spasm, and sometimes it thrombus very rapidly. So procedure ultrasound is the key when when I decide for radial artery puncturing, because again you may appreciate stenosis on the angiogram, but it may not be there also.
Thank
So
you.
putting balloon in a non-affected area, I am always worried. So pre-operative Doppler will decide whether I will do any intervention in radial artery or not, and which approach I will take. And just one more question. You must have done Doppler for this patient, right? So
Yes,
what
sir.
was the thrombus extension? Because you had a stenosis at elbow also, and you had a stenosis at the juxtaanastomotic area. So with the
The
thrombus
thrombus was,
extending.
no, sir, it was from the anastomosis to around 3 centimeter downstream.
Okay, okay. So then it becomes easy to go from the radial approach, because sometimes coming from
Sorry.
fistula, we may
Sorry.
push that thrombus sometimes into the artery also. So that is again a worry when we do retrograde, and
Yes, sir.
especially when the fistula is not very much well matured, because you told is 3 weeks old,
Or enough.
then we may not be dilated enough to get a puncture very easily. So that is my take on this particular case. But definitely procedure Doppler is a key for me when I do any intervention through radial artery.
Thank you. Thank you. I think we have learned so much out of this case, but our intention was to mainly encourage people, not to, uh, not to give up when they see a total cutoff and they are not able to enter the way. Okay. Anish, you go on to the next case.
Yes, sir.
Sure. This is an interesting case. I don't know if you remember, I once presented AV fistula created by nephrologist of different kind. It was AV fistula in the kidney post biopsy, after biopsy. So then how I tackled it with coiling. So like that, in this case, yeah, carry on. There was a funny
Yes,
thing
sir.
happening. Yeah, come. Yeah, you
So,
take a quick work of the presentation. Okay.
yes, sir. This is a 57-year-old lady, again a known case of CKD on maintenance hemodialysis. She has a right radiocephalic fistula that has been placed 1 year back, and since one day she is complaining that there is no thrill in the fistula. So previously she had a left radiocephalic fistula and a brachiocephalic fistula that had primary maturation failure, and she also had a right IJV non-terminal catheter that was in place for 2 months before the right radiocephalic fistula had matured. So when we took the patient for a Doppler, so we can see that the dextroanastomotic region is filled with a thrombus in the vein, and we also took a Doppler of the radial artery, and as we can see that the proximal and the middle part of the radial artery is showing good monophasic flow, but the distal radial artery is hardly showing any spectral waveforms. So we took the patient to the cath lab and we put a radial artery sheath and we took an angiogram. So again, there was complete cutoff of the right radiocephalic fistula, and also there was cutoff of the radial artery as well. Only a small trickle of contrast was there across the anastomosis. So we took a Terimo 035 wire and inserted it through the radial sheath. We are lucky that the guide wire went through the anastomosis into the AV fistula, and we forwarded it so that it crossed the elbow, went up the basilic vein in the arm, crossed the shoulder, subclavian vein, went to the RA, into the IVC. This is the angiogram that was taken after placement of the guide wire. So here also we can see that there is hardly any flow of contrast, only a thin stream of contrast going along the guide wire. So after that we put a 4 by 40 balloon and we placed it across the, we made it cross the anastomosis, and we have marked the anastomosis site with the index finger, and we inflated the balloon at 10 atmospheres. So after this, we again took an angiogram. Now we can see that the flow had improved to a great extent as compared to the baseline. And this is the angiogram again taken at the elbow. So here we can see that the guide wire has gone into the basilic vein, but the contrast is not going into the basilic vein. So we thought that there will be another stenosis around the elbow also. These are the angiograms around the shoulder. It is showing patent flow up to the right subclavian vein. So we took a 4x40 balloon and we placed it across the stenosis around the elbow and we dilated it to 10 atmosphere. And we took an angiogram again. This is the distal forearm, again showing adequate flow. This is around the elbow. Now we can see that the contrast is going along the guide wire into the basilic system. This is around the elbow, above the elbow. Again, the contrast is going into the basilic vein. After that, we took a 6x40 balloon and placed it across the stenotic lesion and dilated it to 8 atmosphere. And then we dragged the balloon down up to the anastomotic area and we inflated it again for 8 atmospheres. So this was the angio taken after the final dilatation. So we can see that there is good flow of contrast into the radiocephalic fistula. So we wanted to image the radial artery as well. So we compressed the AV fistula and put some contrast, but there was complete cutoff of the radial artery. There was no contrast that was going into the radial artery. So we pulled the guide wire down up to the point that it came out of the anastomosis. Then we compressed the AV fistula and pushed the guide wire forward. And in the video, we can see that the guide wire has now gone into the radial artery. So after that, we took a 4x40 Mustang balloon. And we had already previously marked the region of overflow that was starting somewhere in the mid forearm. And we suboptimally inflated the balloon to 3 atmosphere only and slowly dragged it down the radial artery from the elbow to the anastomosis. So this is the final angiogram, which was showing good flow in the radiocephalic fistula. I'm sorry, actually, there was a video of the radial artery as well, which was showing good flow of the contrast. I don't have that video as of now. And this is the angiogram around the elbow, which is again showing good flow. So we were happy with the procedure. But the next day when we saw the patient, she was complaining of pain and swelling in the right upper limb. So we again took her for a Doppler. The radial artery was showing good flow and the AVF was also patent till the right subclavian vein. So we thought it will be some reactive swelling because of the procedure. So we advised her for arm elevation, soft ball exercises, hygroscopic dressing. We gave her antiplatelets and discharged her on oral antibiotics. So at this point also, we failed to take a picture of the arm. It was quite swollen. But 2 weeks later, she returned to us again. And the swelling had come down, but the swelling, as we can see, there is still some degree of swelling in the right upper limb, such that the dialysis technicians were finding it hard to cannulate the fistula. So we took the patient for a central venogram, and it was given that she had a thrombus in the right brachiocephalic vein. So again, we took the patient to the cath lab. And this time the patient already had a right femoral HD catheter in place. So we put in a guide wire and exchanged that catheter for a 7 French radial femoral artery sheath. And after that, we passed a 035 guide wire along with a 3.5 centimeter 6 French diagnostic catheter. And we parked the tip at the junction of the right and left brachiocephalic vein. After that, we took the angiogram. And this was the angiogram. It showed a complete cutoff of the right brachiocephalic vein. And also there was a stenosis of the distal left brachiocephalic vein. So we tried to pass the guide wire through this thrombosed right brachiocephalic vein, but every time we tried, it was just going into the left brachiocephalic vein. And after a lot of efforts, we were unable to pass the guide wire through this thrombosed segment. So we cannulated the right cephalic vein of this patient and we took an angiogram. So the cephalic vein showed good patency and flow of contrast. This is the angiogram of the cephalic arch, which showed again good flow. After that, we put a guide wire and a 3.5 centimeter 5 French JR diagnostic catheter, and we manipulated the JR diagnostic catheter to reach the cephalic arch, as shown in the video. Then we took one more angiogram, and this in the angiogram also we can see that the dye is not going into the right brachiocephalic vein, and there is a complete cutoff. So we put a 035 Terimo guide wire and we manipulated it somehow, and luckily for us, it went into the thrombosed segment and entered the superior vena cava into the right atrium to the IVC. After that, we passed a 4x40 Mustang balloon and we placed it across the thrombosed segment, and we have just confirmed the location on this angiogram. And after that, we inflated the balloon at 14 atmospheres, as shown in this video. After this inflation, we put a guide wire through the femoral root and we manipulated it somehow, and it entered into the thrombus segment and went into the left subclavian vein. So in this image, we can see two guide wires. The one on the extreme left, it is the one that we have passed through the cephalic vein. It has went through the cephalic arch into the subclavian vein. And the other guide wire is the one that we have passed from the femoral root, and it has crossed the subclavian vein and it is going into the basilic system. After that, we passed a 8 by 40 mm Mustang balloon from the femoral root, and we made it to lie across the thrombus segment and inflated it to 10 atmospheres. So at this point, we decided to try something new for us. Like, we already had a 4 mm balloon that was parked nearby, and there was a 8 mm balloon that was already parked in the thrombus segment. So we advanced the 4 mm balloon so that both the balloons were made to lie in the thrombus segment, and we simultaneously dilated both the balloons at 8 atmospheres. So this was a simultaneous balloon inflation technique that we tried. But after this, we again took an angiogram through the cephalic vein axis. And this angiogram showed some recanalization, but there was significant residual stenosis and thrombus load was still present. Then we took out the 8 mm balloon from the femoral root and we placed a 12 mm balloon and we inflated it at the thrombus segment, as we can see in the video. Then we pulled the guide wire down and manipulated it to enter the left brachiocephalic vein. And we again inflated the balloon at 10 atmosphere for 30 seconds. And we can see that the waste, the stenosis is slowly disappearing. After this procedure, we took the angiogram of the left brachiocephalic vein. We can see that there is good flow and the stenosis is no longer there. Then we took angiogram of the right brachiocephalic vein. This also shows good flow. This is one more angiogram of the right brachiocephalic vein, which is showing good flow. But however, there is non-homogeneous opacification in the right brachiocephalic vein. So probably there is residual thrombus still left in the brachiocephalic vein. So we discharged the patient and she came back to us after 2 weeks of the procedure. And now the swelling of the right arm had completely subsided and we were able to achieve cannulation of the radiocephalic fistula. So some points that we wanted to discuss for this case was opinion regarding arterial interventions like in this case, and experience regarding simultaneous double balloon angioplasty. Like, is dilating two balloons, one 4 mm and one 8 mm, equivalent to dilating one 12 mm balloon? And opinions regarding what can be done for the residual thrombus load.
Thank you, Anish. I think who is going to start answering this? See, we failed to take a photograph of her. See, you do a procedure and you think you succeeded. She comes back with actually the photo we missed. Huge swelling of the upper limb and the face, and it was so scary that we felt we have done something wrong. But the radiocephalic was working fine. And then so we have brought out an occult central vein stenosis by opening the radiocephalic. So that's what had happened. And we did pass the guide wire, if you remember what he showed, into the SVC, up to SVC when we were doing the radiocephalic. That didn't have any resistance, nothing. So we thought we didn't take a check angiogram then, but maybe there was some flow that time. So this is an instance where opening the radiocephalic has surfaced or brought to light an underlying central vein system. That was interesting. And this using two balloons, it might look easy, but on the table, we didn't know that there ever exists a procedure like this. Out of necessity, we didn't have very big balloons. So we thought, why not do that? Then after that, only we started reading about it. And then there was another message from this case. And we did notice the residual thrombus. And I remember somebody telling me once you have opened up, it will be flushed through to the central system, the SVC and atrium, it will go up. You don't need to really anticoagulate very heavily. So all these points I thought we'll ask from the August panelists because we were naive when doing all these interventions. And the artery also now we know that you've all been doing it arterial intervention, but that time we were scared to meddle with the artery. Because when you do anything, you can at the worst you'll have swelling, but if you do something to the artery, and if the patient happens to lose the limb, that will be a big mess. So yes, please start.
So, Anish, nice presentation, but I have multiple thoughts, but I'm just going to start off with one thing. Even in your very first angio, the central vein occlusion was very apparent. You were able to cross the wire and easily without any issues. You opened the inflow, you opened the outflow of the forearm vein, and you created a path for the upper arm cephalic. Um, any reason why you didn't go after the right innominate vein at that stage itself? Because for me, like if you think about it, if you have an outflow which is already blocked to, that it is very apparent, and then you increase the inflow and flow into the fistula in the arm, venous hypertension is a natural consequence of it, right? So what you got with the arm swelling was quite predictable. But I was just kind of curious. You already had the wire, you already had everything, and you took care of the only the arm, but not the central. But I was just kind of curious what your thoughts were at that time.
Yeah,
It was
you're
something that,
yeah, carry on.
yeah, and that was something that we missed, sir, actually, because the guide wire had easily passed and we had imaged up to the subclavian vein. So we did not think that there will be a thrombus there. Yeah, we should have checked the brachiocephalic also and done the intervention in the same setting only.
Yes, but Anish, actually now looking through the angios playing, there were collaterals then, if I remember, if you read,
Yes, sir.
see, that should have made us think about further stenosis in the center.
Yes.
Yeah, we missed.
But patient never had a edema before, right, sir?
No, no.
Yes, sir.
So was it because of the basilic vein which you dilated and which led to increase in flow? Because patient had a functioning RC, and as we all know, RCs are very much unlikely to produce venous hypertensions very easily. So opening up basilic vein, which was maybe not may not be the reason for the symptoms or a culprit, we opened up basilic vein which led to increased flow. Do you think it may be the reason for the that stenosis which was not present before clinically, and it become significant afterwards?
Yes, sir. Probably because the radial artery, the artery fistula got thrombosed only 1 day back. Before that, also she did not have any swelling. So maybe it was masked by the basilic vein stenosis, that opening up the first the apparent central vein. So,
No, I think
So that
the flow also would have been little lesser. The
yes,
flow would have been not big enough to cause the symptoms. Because ultimately, no matter which venous pathway it takes, it ultimately has to go through the subclavian and the brachiocephalic way. So probably the flow was not good enough, and that could be the other reason why the fistula also clotted. And the moment we increase the flow, then the symptoms manifested. I mean, that is one of the things I can think of.
Anish, unshare so that you can see the speakers.
maybe that arteriopathy that the patient had, that was masking the symptoms. When we opened up the artery, that caused the problem.
And we were thinking whether the thrombus load in the forearm went up and occluded the vein. I mean, we were thinking of so many things. We were putting the blame on ourselves that we have created this problem to have. But everything is
Sir, as I was seeing, there was a small opacity in the cephalic vein also, sir. Like probably that was a thrombus that was migrating.
yeah. But could that be the only? I mean, the thrombus now we saw in the central vein can't be, no. So that should have.
Yeah,
Uh,
yeah.
yeah, that's a condorum. Like typically, if there was no arm swelling before the procedure, um, I typically will not do anything to a clearly visible central vein stenosis, even if it is 60, 80% stenosis, because we have shown that doing preemptive angioplasties on this without any symptoms does not really have a very good primary patency. So yeah, in this case, I think the flow, which may have been, low at 500, 600 before you did the procedure, you increase the flow up to 1,000, and now suddenly that problem became unmasked. Um, the question about using a single balloon or two balloons, I typically have never used two balloons. I know this is really common practice with interventional radiology. Crossing the central vein total occlusion is a challenge, and there are some dedicated wires that are available. We use one of the Boston Scientific, I think it's called the Victory wire. These wires are very heavy weight at the tip, and that kind of helps you to kind of cross that area a little better. It helps sometimes if you have a target through the femoral axis and a target through the peripheral fistula, and you'd be able to see if you are in the right direction. There is always going to be a risk of perforation. So once you cross it, you have to confirm that you are in the right area. And whenever you do this, you will have to make sure that you have a stent, because we've had cases where there will be a rupture when you open that stenosis, and that can cause some mediastinal bleeding, and then you may have to be prepared for a covered stent application. Um,
The
right.
only
I have
reason,
to check out because there's a lot of noise in my background. We can hear. But thank you again for inviting me, and I think we have some really good cases that we're discussing. So sorry for the early leaving.
thank you, Bharat. Yeah, so we'll meet in another meeting. Uh, the only reason we took two balloons was to, I thought we'll save cost by not using a bigger size balloon, without knowing much about it. You share and show those slides, the theory behind it. Then we later only we started looking at the literature and instances of using double balloon. Are they same as using single balloon?
So we looked up for some literature to see if dilating a single 12 balloon is similar to dilating one 4 and one 8 balloon. So the differences they have mentioned is the balloon geometry and vessel contact. Like a 12 balloon will act as a single continuous cylinder, and it will apply continuous radial force across the 12 diameter. But when we inflate a 8 and 4 balloon, placing them side to side, it will not create a uniform cylinder. It will be in the form of an elliptical shape. And there will also be a groove between the two balloons, and the force will not be equally distributed across the circumference. So the pressure distribution will be very much different for both the cases, and a single 12 balloon will cause even pressure across the vessel, but two smaller balloons will cause localized pressure, and there will be incomplete lesion coverage and non-uniform dilatation of the vessel. So clinically, they say that at bifurcation lesions, two balloons can be used, but for full lumen concentric dilatations, we should use a single balloon. And even if we look at the cross-sectional area also, a 4 and 8 balloon will have an effective cross-sectional area of around 63 millimeter square, but a 12 balloon will have an area of around 113 millimeter square. So the area of dilatation will also be quite different for both the balloons. So this is just a table to summarize what we have discussed. The differences between a 12 balloon and dilating a 8 plus 4 balloon at the same time.
Yeah. So size wise, this is not equal. 8 plus 4 will amount to only 9 or 10, something like that. Okay. Any comments on this use of double balloons from any other panelists or audience?
So not the double one, but the way you inflated a balloon in radial artery and that semi-inflated balloon you pulled it down. So I'm always afraid because
Yes.
for any arterial intervention, as you also do renal artery and I also do renal artery, it is always dictum never pulled back any inflated balloon into the artery, because you may denude the endothelium and you may produce thrombosis and stenosis, which is actually not there. So, any comment and maybe your thoughts on the same?
Yes. I think actually my next doubt was how to handle arteries while doing this procedure, because we have never done. So what care we should take, and
But
dilatation, and definitely not
again, Because anyway, your fistula started flowing well, so I will just put my do my clinical examination. Feel is good. Doppler is showing adequate flow. I will not do any radial interventions if it is not really bothering to my fistula, because indication of for doing radial intervention in that this particular case was your own finding, uh, and the getting the fistula working. There is no limb ischemia to do any radial intervention. So if your fistula is
uh,
functioning well, then we can certainly avoid doing intervention in the radial artery.
but the angio showed no flow in the radial artery, proximal radial artery.
But again, I would maybe put a catheter in the radial artery and then take an angiogram and then just demonstrate that the flow whether is there or not. Because
Uh,
whatever we inject from radial artery sheath, I think with the fistula were functioning well, it is not likely to go into radial artery.
yeah, we blocked the vein completely and tried, and we saw it getting obstructed somewhere. And that's why we ventured. But the right way of doing how much to dilate, whether the arteries behave differently from veins. You know that, so we need advice on that also. So
Because Doppler and clinical examination at that point of time may be of some use, because if the thrill is good, then obviously there is some flow which is coming from somewhere, whether it's a distal radial artery or a proximal radial artery, because fistula, when it starts functioning, obviously flow is coming from somewhere.
So that is why when she came back with the swelling, pain, and that thing, we were doubly scared because we had done something to the artery, or something very wrong has
Yeah,
happened. Okay,
same I was thinking at that there must be something with the artery only.
okay. I think anything else we can have it at the last. We'll, thank you, Anish.
Thank you.
Karthik,